those who sector coordination, I usually prefer the panelists themselves to come and pour the IV to the audience. Welcome, Dr.
dialogue, public-private collaborations at the ministry level. We have quarterly meetings with all the ministerial stakeholder forums, with CS, which are co-chaired by the CS Health, and our chair, who is Dr. Gakombe. And we also have technical working groups that basically cut across all the subsectors of health, and our membership comes, drawn from all the subsectors of health. Basically, human resources for health, digital health, health financing, and so on and so forth. So supply chain and the entire. So for us, what is critical, and we're very grateful to the Ministry of Health. Dr. Lenai is really the link between us and the Ministry of Health. Does a very beautiful job, I must say. So thank you, Dr. Lenai, for bringing us together, but also to just reassure you that as a private sector, we're very committed, especially during COVID time. We really mobilize the private sector as Kenya Health Declaration and also as KEPSA to support the government in the response to COVID-19 and to continue to look for opportunities for collaboration. So thank you very much.
A round of applause again for Dr. Nyalita. Thank you, Madam CEO. As I said, PPP is very key as we aspire to achieve our goals. So it's very, very key and very important that we cannot do without it. Audience and colleagues, allow me to invite the next panelist to introduce himself, and that is none other than the CEO of NHIF, Dr. Kamuni.
Thank you very much, Dr. Lenai. Ladies and gentlemen, good afternoon. It is indeed a great pleasure for me to be here. My name is Dr. Peter Kamuni. I work for NHIF, and from February of this year, the NHIF now stands for National Health Insurance Fund. And it is indeed a great milestone for us, because it is that amendment of that act that now we'll be able to scale up to be able to achieve UHC. And as we heard Waziri say, that UHC is not akin to NHIF, it's actually the whole of the healthcare ecosystem working well to ensure that all our citizens have access without suffering financial hardship. So my background, so since you introduced myself, Dr. Lenai, I've been in the healthcare financing industry now for the last 23 years. Actually having worked in most of the healthcare ecosystem, from insurance, national hospital, pharmaceutical, and now the national health insurance. So I think with that 360 view of the healthcare industry, I'm very happy to be here. It's actually now 2 years, 2 months, exactly 2 months since joining NHIF. I'm sure for many of you who interact with it feels like it's 2 years.
A very good round of applause for Dr. Kamunya. Thank you, thank you. Colleagues, next I would like to invite Professor to introduce himself. And I think that's the heaviest CV which is around. And as I said, my tradition is to let people talk about their CV. Over to you, Professor.
Thank you, Dr. Lenai. I am Richard Muga. I am a CEC of Health Services, Homa Bay County, and I chair the caucus of CECs at the COG. Previously, I worked at Ministry of Planning and National Development as a CEO for Population and Development. And yes, then I forgot, I also worked in the Ministry of Health as a DMS for 5 years. And then I worked at my university, Great Lakes University. I was DVC Finance and Administration for 8 years. And then before I went to Homa Bay County, I was teaching at the medical school called Ozima. But bottom line, we are practitioners in healthcare. Thank you.
A very good round of applause for Professor. And he is actually also a pediatrician.
Yes, I forgot.
Let's clap for Professor. Thank you, thank you. Most of the books and the policies we still refer to mostly were made by Professor during his time. So we really, really want to thank you for the good work that you have been doing. Lastly, I would like to welcome my colleague to introduce himself. But before then, because he is the first keynote speaker, I would like to introduce myself, the moderator. My name is Dr. Lenai Joseph. This is the Director for Health Sector Coordination and Relations, that is intergovernmental and international at the Ministry of Health. I have been a CEC also, and also have been a leader in the CECM caucus. And before then, I was a Director for Health in Nakuru County. Before then, I was a District Medical Officer of Health, a MediSoup in several districts in the nation. So with that, clap for me. Then I welcome my colleague, who is the first keynote speaker. We are going to have him make his deep dive speech and remarks. Then after that, we shall have a deep dive into the intergovernmental led by Professor. Then the panelists will come in. Then after the panelists, we shall open the plenary to the audience where you'll have to ask questions. Over to you, Dr. Mulwa. Welcome.
Thank you, Director Lenai, for the opportunity. My name is Dr. Andrew Mulwa. I am not sure whether I should introduce myself or introduce the person that I'm representing today, Dr. Mercy Mwangangi, the Cabinet Administrative Secretary in the Ministry of Health, whose shoes I'm wearing today. So I am not sure whether this opportunity is to introduce myself because I'm only representing her. But for avoidance of doubt, I am the Head Directorate of Medical Services, Preventive and Promotive Health in the Ministry of Health. Having done now 1 year in that portfolio, and today is 20 what? Today is, I have no idea which day it is. Today is 28th. So having done 1 year and 7 days, that is 1 year and 1 week in that portfolio. I also served as the CEC for Health in Makueni County from 2013 to last year, which is 8.5 years. And Professor failed to introduce me. I thought I would be introduced by a professor that he succeeded me as the chair of CECs for Health. So I was the chair of CECs for Health between 2015 and 2021. And today I began my day in this very hotel, but in a different stakeholders forum for HIV. Also had, we are launching the mental health investment case in another hotel in the city. We are also launching the national breast cancer and cervical cancer investment case in another hotel in this city as well. Then I find myself here. I will go straight to make remarks or keynote speech on behalf of the CS Ministry of Health, Dr. Mercy Mwangangi. And ladies and gentlemen, all protocols observed, I am delighted to join you today as we discuss the topic on sustainable financing for transfusion and transplant services in Kenya. This conference is crucial, especially because Kenya and the world at large is committed to achieving universal health coverage, which requires adequate and sustainable financing. Kenya has experienced strong economic growth of around 5.6% on average in the last 5 years, making it the 5th largest economy in sub-Saharan Africa. In 2014, with the rebasing of Kenya to middle-income economy and reclassification, therefore, this necessitated the country to progressively increase domestic resources to finance healthcare. Further, COVID-19 brought about disruptions across the world and necessitated investment in health services. In response to these needs, there has been tangible commitment of the government to implement UHC, one of the big four, set by His Excellency the President. The government has significantly increased the healthcare budget between the financial year 2018-2020 and the year 2021-2022. While it is noted that more needs to be done, access to quality health services without going into financial hardship has considerably improved. Counties have utilized their resources to enhance their health services, with commitment of up to 35% of their overall budget on health, thus improving primary and tertiary health care. The results of these investments continue to be seen. Between 2013 and 2021, an example is dialysis services in the country has increased by 2,000% to reach 603 across the country. There are 42 MRI machines, up from 20 in that period. Of importance is the cost saving achieved through investments in radiology, the Linda Mama, the ICU beds, which came in handy during the COVID-19. I mentioned already dialysis, which amounts to 131 billion Kenya shillings. Ladies and gentlemen, the financing required this financing is required at a time that Kenya faces epidemiologic transition from predominantly communicable diseases to non-communicable diseases. We are also undergoing a demographic transition where more people are living to older age and hence increased health care needs due to diseases and conditions that are associated with aging. This in turn means that additional and sustainable resources for our transfusion and transplant needs are required. Sustaining the financing is about prioritization and ensuring efficiency and equity in resource allocation. In working towards the advancement of transition preparedness, tackling the challenges of sustainable financing, the ministry developed a roadmap for transition from donor aid to sustainable health financing. The implementation of the recommendation of the roadmap is underway and has included 1, the approval of the Kenya Health Financing Strategy and UHC policy that will enable the country to move towards attainment of UHC. 2, the development of UHC Essential Benefit Package to provide financial protection to Kenyans seeking health and ensure accessibility. 3, identification of 1 million households with an allocation of Kenya shillings 6 billion that will benefit from UHC Essential Package and offer financial protection to vulnerable Kenyans through NHIF. This is in addition to other programs, that is the Health Insurance Subsidy Program, the Linda Mama Program, the Elderly and Orphans and Vulnerable Children that have been ongoing. I am pleased to note that this package incorporates blood transfusion services. Ladies and gentlemen, with the increase in prevalence and incidence of non-communicable diseases and concomitant existence of communicable diseases, the country is witnessing increased demand for blood transfusion and organ transplants. Human-derived medical products, including blood cells, tissues, and organs, form an essential part of health system and a primary requirement for attainment of UHC. So, the Kenya National Blood Transfusion and Transplant Service is engaging with the ministry to expand the UHC Essential Benefit Package to include transplant services like corneal, skin grafts, liver transplant, etc. It is notable that in 2021, the National Health Insurance Fund covered costs of up to 700 million Kenya shillings for kidney transplant locally and up to 1 million abroad. With expansion of transplant services in our hospitals and investment in support systems for donation, organ banking and typing, and an equitable allocation scheme, with expansion of transplant services in our hospitals and investment in support systems for donation, organ banking, and typing, and an equitable allocation scheme, these costs can be integrated in the UHC package. It is anticipated that this will cover costs related to medical care of organ donors who currently are largely family donors and usually have to cater for their own medical costs. Post-transplant medical costs that are usually long-term or lifelong are part of the care package being explored. These costs vary dependent on the nature of transplant, but largely act on clinical immunosuppression that occurs post-transplant, including anti-rejection medications to reduce your immune system's ability to reject a transplant organ. I am midway through. The rising costs associated with organ transplant services will only be stemmed with investments in preventing clinical progression of disease. The interface between non-communicable diseases and organ transplant is well documented. The expanded services for treatment of cancers, kidneys, and liver disease will allow early treatment and improved outcomes, thus mitigating. With specific to costs of these products in the private sector, there is need to promote equitable healthcare, as indicated by the Cabinet Secretary in the opening statement. Where private facilities receive blood products that have been donated, screened and typed by the government, charges must be commensurate to their operational costs and not exorbitant. The costing of blood and products will provide reference for use. A critical aspect of our healthcare progression is the management of blood and bleeding disorders. Transfusion costs for blood products will continue to be covered through NHIF. Additional costs that are currently not covered will be part of the exercise of developing comprehensive cover. This will ensure that Kenyans living with blood disorders also live a high-quality life. The commitment of the government to UHC and the financing of blood transfusion and transplant services remains. This conference, therefore, provides an opportunity for all stakeholders to deliberate and make recommendations towards securing this commitment. For and on behalf of Dr. Mercy Mwangangi, the Cabinet Administrative Secretary, Ministry of Health. Thank you.
Thank you, Dr. Mulwa, for and on behalf of Dr. Mercy Mwangangi. Dr. Mulwa has taken us through the broader agenda of status of UHC and financing for transplant services for Kenyans. And in that broad approach, we have heard that the budget has been increased. And of course, a lot of investment has gone towards matters of universal health coverage. And at the end of the day, the health economists are telling us that a lot of cost has been saved. In addition, again, we find there is a whole shift in terms of budgeting and financing and resourcing from communicable diseases towards the non-communicable diseases. Very, very key words also we hear are a matter of prioritizing efficiency, in the allocation as we do the allocation. There is a shift. We are being reminded about moving from donor dependence to having a roadmap to self-sustainability and self-reliance. And very key, we are being guided to look at the recently launched UHC policy. Notably, there is increased demand for blood and blood products, and the UHC journey and conversation has looked at the UHC essential benefit package, which all of us have to be referring as we offer services. And very, very key, we note that NHIF has already started packaging and even offering and even paying for transplants, especially renal matters and kidney transplant. And there is also the call about expansion of the UHC package. With that, I would like, let's put our hands together so that we give Dr. Mercy through Dr. Mulwa a round of applause. Thank you. Now, having had that broad perspective on roadmap to sustainability, we need to realize that Schedule 4 of the Constitution stipulates that there are functions that are supposed to be at the national level, and there are functions that are supposed to be at the county level. In addition, again, of course, we need to have a way of really gelling together these two functions and these two inseparable entities. And blood transfusion and transplant is a matter of concern to all of us at any level. And in order to make sure that we all read from the same page, the Intergovernmental Relations Act allows we develop regulations which enhance this consultation and relation. And again, also, the Intergovernmental Relations Act allows we come up with the frameworks. Colleagues, at this juncture, we want to listen to that intergovernmental framework as the foundation of sustainable blood transfusion services in Kenya, led by none other but the chair of the CECM caucus, Professor.
Yeah, clap for him. That is a very weak clapping because he has talked very well. Thank you very much, Director Health Services, Dr. Mulwa, whom I took over from as a CC chair. Now I have said it. Yes. And then the CEO for NHIF, my colleagues, ladies and gentlemen. For me, it is, can you put a slide? For me, it is an opportunity to share with you, having worked as a rural doctor, I was once an MOH, then I became a PMO. Some of you may not know what was a PMO. I became a PMO. Then later I had opportunity to work at policy level as a director of health services. And I want to tell you it's been a rich experience that as I move on, I teach my students, the young doctors, what journey we have walked and what are the gaps. And so when we talk of intergovernmental, slide 2, intergovernmental framework, I want you to look at this map with 47 governments and then one central government. Very important, because this is where we must start. With the 2010 Constitution, which is available for us, which made the best thing which happened to Kenya was devolution. And we have moved further to see if we can put the counties into blocks. So we have a national government, 47 counties, then we have regions, LREB, with a number of counties, then the north, and then Jumia, and you can continue. So, if we are going to have gelling together, if we are going to work together, we must find a mechanism which allows these people. Like for me, I come from Homa Bay, I have a governor called Cyprian Awiti, and he sits on his chair properly, and he says he's a governor. So if you want to talk to him, you have to know how to relate to a governor. Then you continue to Kisumu, you find Governor Nyong'o. And then you can go to Machakos, you can go to Mandera. This is the issue. And yet health is fully devolved, meaning that blood is transfused at the county level. Blood is collected at the county level. And yet we don't want wastage. And wastage comes that we go for an effort in the field, and then we collect 200 pints of blood. Then I bring them, squeeze them in Homa Bay, and I rest that I have 200 pints in the blood bank. Then after a short time, they expire. Then now we have to throw them in the incinerator. How do we make this thing work? I want to say that we need a process that will allow county government to sit around a table, private sector to sit around a table, non-governmental organizations like churches, national government, and then we have partners sitting around a table. And so we need a legal framework that allows something like a board, and that board must have representatives from the counties, and then private sector, and then the national government. And you will find stakeholder representation in this. And then we will then be able to have to develop policies like what was launched today, the standards, and then regulation for blood tissue, a tissue that is blood, and then other tissues like kidneys. And going forward, we will have to raise resources, mobilize resources. And then we will also have to develop a human tissue register, both at the national level and down at the regional level, and down even to the county level. And that we can have tissue banks, like we were told this afternoon. And then we will have to have guidelines, like you heard them, the professors in the morning say, that we have to stick to quality. And therefore we are proposing, and this is what I raised with the cabinet secretary, that in his wisdom he could consider creating something like that, that could allow us to move to the next stage. And in that process, we will develop a, next slide, slide 3, Polly. We will develop a pot. We are all used to pots. You put water, you put porridge in the pot, or you can have a basket. And this will allow counties also to contribute. And they will give as per what they can afford. And then we will allow other stakeholders, groups like PEFA the other day, we need to urge them so that we come together. Then we will have a fund manager that can receive these monies or allow these monies to be used at the level of the county so that we don't transfer money, but we are able to implement activities. And some nominal fee, like what I have proposed here, don't say why 5 million. I am saying this one we will have to debate at the COG and agree. But if each county was to contribute budget, 5 million in their budget, like myself, I could put that budget. And then my colleague from Kajiado can also put that budget. Then gradually we can build a fund that not necessarily relies 100% on donor support. And this money will have to be audited. So you will have a basket with regional centers where we have already existing blood donation units, blood processing units, and then you will also have health facilities like we put in that, and then you have the patient at the lower level. Like Professor Kama said, we don't have shortage of blood. And I was thinking about this, what does it mean? I think we still have a lot wasted that we can do better. And then, okay. We have the concept that has been used now in UHC, the hub and spokes. So we could create a situation, and these spokes could be facilities, or they could become regional centers. And all this will dab into our implementation of universal health care coverage. But then once I have blood in Kisumu, and somebody requires it in Mfangano Islands, we have to have a mechanism of moving the exact component that is needed. If it is platelets, to move into Mfangano level 4 hospital, we should have a mechanism. And this is why we say there could be many ways. But recently, the governors of LREB have visited Rwanda to see how they use drones. And it can carry 3 units of blood or different blood products. And we are saying that we pull blood, we have ability to move it where we want, safe blood, good quality, so that we save life. And then, so you will have to fire a drone. And Professor Nyong'o, who is the chair of the health committee, was very excited to see that we can stand in a level 4, blood is sent, and in 7 minutes, blood has come there. And not whole blood, the component that we need. And so we are saying that technology must now come in, like what we launched today, to be able to help us to improve this process. And the governors in the LREB are launching a zip line or drone next month, which will start to distribute safe blood and vaccines in 14 counties. And my colleagues from the LREB, they know. But that is not enough. We need another one in Coast. We need another one in the North. We need another one so that safe blood can move across the counties. And in this visit, you know, he's also controlling me there. Next. Yes, this one is showing Governor Nyaribo, and showing Governor Ongwae, and showing Governor Nyong'o. The next one I don't know. And so we went to learn, to benchmark, and it can be done. And we can save blood. We can save money also. And so you could go to Parliament to make this legal frame, but sometimes those of you who are working in the center, you propose a bill, you send it to Parliament, it doesn't go through, you come back, and then you restart again. And you can do it 2-3 times. Mulwa, he has gone. Oh, Mulwa has left me. Then, and then you would find that each county must budget. And my colleagues, CECs who are here, we are the ones who need blood and blood tissues most. And we can push it into our assembly so that some money is allocated. But then we will have to have the policies, and our friend from NHIF is here. We are saying this money which counties are going to budget for, it can be part of the claim that we make from NHIF. and therefore we are able to contribute. And therefore we'll get blood at the time when it is needed, free, no charges, without wasting. And if we do that, we can improve the health of our mothers, the people who live with sickle cell disease, the hemophiliacs, and the dear lady who cried this morning, who told us a very painful story. And then we will get the private sector also to participate. And therefore, my colleagues, blood saves life. And blood is a tissue. Professor Kama told you. Blood is a tissue. Quite often, people do not know that blood is tissue. And we need timely availability. And we have to have this frame that everybody has a voice so that it can work. And if we do that, we'll be promoting health systems development that will allow access to safe blood and other technologies. And then we will have sustainable financing because everyone can follow where the single cent is going. You know, nothing for us without us. That's a great saying. And so we want to indicate that through this process, we will lobby that county governments, they second human resource to all this umbrella. So that, like today, I came with my 3 officers from Homa Bay. One is a health administrator in the hospital. The other one is head of laboratory services, and another one working to ensure that blood is available. They are key people, and we can second them to this process. That is yet another contribution of the county government. So, ladies and gentlemen, the counties will develop infrastructure. The counties will use the guidelines. The counties will have a register where the donors are listed. And we can call you anytime to be part of the safe blood donation or kidney donation. And if we have properly managed health information system, I think we can move ahead. So I put it to you, it is possible to do it. Thank you.
Thank you, Professor. Thank you so much for having a deep dive into the intergovernmental framework and really showing us the opportunities that are there especially from the counties, what we can be able to do in order to change the narrative. Professor has also reminded us that we don't need 47 frameworks dealing with the national government or national government dealing with the county government. We don't need more than 100 frameworks when we are dealing with the partners. We all rally ourselves towards this one framework, which is embracing one society, one government approach. Then Professor has also told us that it's possible we have a pool of funding, a basket for funding for matters of blood transfusion and transplant. And counties can come, maybe riding on the economic blocks that are there. Lake region has already taken that lead. All the others also, Central Economic Region, needs also to come in, Southeastern, Pwani, Frontier, all the others, Narok and Kajiado. You need to come together, any framework or any matter that is not just county specific. You need to come together and see how you pull together. And as we look at the budgeting cycle, both at the national level, and also we look at the budgeting cycle at the county level, all of us who are CECs, remember February 28th, which is very, very key in the county budgeting. You need to ensure during that time, when you are coming up with the outlook papers, you ensure that you are budgeting something on matters of blood transfusion and also transplant. In addition, again, innovation is very, very key as we strive also to strengthen our supply chain They have already borrowed the issues of drone. This is doable. So it's good also counties to continue innovating and borrowing technology in order to address this emergency matter. In addition, again, we are being reminded that we need to do resource mobilization. Most often than not, when we think of resource mobilization, people think of finances. There is a resource called blood. There is a resource called an organ for transplant. You need to resource mobilize, especially towards this agenda. And with that, again, finally, he has ended by saying, when we come together as blocks, let's think of how we second human resource into these hubs. A round of applause for Professor. So thank you so much, our presenter, Professor, for that insightful dive into the intergovernmental framework. I know a lot has been talked about the private. I know a lot has been talked about financing. And at this juncture, I would like we go to our panelists, Dr. Peter Kamunyo and also Dr. Anastasia, to give us a perspective, one on financing and the other on private. How are we going to approach it? Sustainability, how has it been? How are we going to sustain? What has been the challenges? And apart from that, what are the proposed solutions? And in addition, what's the global outlook? How is the global practice in terms of blood transfusion and transplant matters? So, ladies and gentlemen, put your hands together. We welcome Dr. Kamunyo to take us into the perspectives of NHIF as a social health care insurer. Makofi. I think you come here, so that they see you.
Thank you very much, Dr. Lenai. It's a very interesting topic, and but I would like to start from this point. The worst thing in a healthcare system is when we lose lives for diseases that can be prevented or patients who cannot get access. And worse than that is when we lose lives in our healthcare institutions because of either unavailability of product or poor quality. We have had it resonating today that blood saves lives, because by the time you're transfusing, it's literally the last resort. By the time you're transplanting an organ, it is literally the last resort. And from where we sit as NHIF, in this financial year that is ending, end of this month, we paid for 172,000 members who required services that required blood transfusion. 172,000 cases. For those of you who've had a chance to read the program, the remarks by Dr. Nduko, you'll notice that she said that in last year, 2021,
Dr. Kamunyo, can we go to sustainability?
I'm getting there, and the reason why I'm telling you this is how we can get to that sustainability. If you look at the statistic that she provided, 2021, there were 297,000 blood donations. and benefited 280,000 patients. Now, what does this all mean? And you've heard from the speech presented by Dr. Mulwa on behalf of CAS that indeed at NHIF we pay for these services because they're bundled in. So when we go to this topic of sustainability, we already have a framework that would be able to pay for the patients when they're in hospital. And we do have a framework already for reimbursement of these institutions when services are rendered to the patients. Of the 172,000 cases, various cases, those hospitals were reimbursed a total of more than 4 billion Kenya shillings. So right now, when we are talking about sustainability and financing, we need to introspect to exactly where is the problem. Because the framework for paying and the framework for reimbursing the hospitals actually does exist. And it is through that framework of doing that that we're scaling up for UHC, which is everyone having access to care that they need without financial hardship. But as Waziri said, that is not the only component of UHC. It is the other issues from supply chain to, like in this case of blood donation, storage, transport, and also in some cases payment. So I want us to be candid and look at the areas that we need to address in order to ensure that these services are available affordably, and available consistently.
Dr. Kamunyo, is blood transfusion one of the package that you offer in NHIF?
Blood transfusion is not a package, it's part of treatment.
Okay.
And of the treatments, like you've had the lady who had ulcerative colitis earlier, suffering perennial anemia, requiring blood transfusion. So for inpatient, for example, constitutes the highest benefit on our packages, our 10 packages that we do blood transfusions, which is already embedded. The other packages that we do a lot of blood transfusion include surgeries, include cancers, and it includes transplants. In fact, in the last financial year as well, the one ending this time, we have had a total of 88 kidney transplants. Now, of those 88 kidney transplants, 10% only are the ones done in public facilities, 12% done in faith-based institutions, and 78% done in the private sector. So, as we go towards the question again of sustainability, all these cases were paid for. So what we needed is to have these individuals who need these services covered, either by private insurance or by NHIF as a mode of risk transfer. But the key thing is to have these services available. And if there are people who can only access public facilities, then are the services available at public facilities? If they're not available at public facilities and only in private, then that presents a challenge of affordability and sustenance. So the short and long answer to that question is NHIF does cover for all blood transfusions. It does cover for organ transplants to certain limits. The question is, are these services available in our facilities? are these services consistently available in our facilities? And are these services affordable within our country?
Next question, Dr. Kamunyu. You as the best buy and well positioned by the government and the UHC policy, and I know the reforms that have been going on with NHIF, what are some of the challenges that you have been facing?
Thank you, Dr. Lenai. That is indeed a great, great question. And why is it a great question? The challenges that we've been facing are the ones that have driven the reforms that we are currently going through. And the reform, number one, to transform NHIF into a strategic purchaser of healthcare services. Because even as we purchase those services, one of the key things is, why do we pay the same amount to all facilities irregardless of the outcome? Why do we pay that irregardless of whether the services would be available in full or not? So transforming ourselves to be a strategic purchaser is one of the key reforms that will also ensure availability of these services and also ensure that sustainability, which is the theme of this conference this time. The other key reform where we are having challenges and where most of our members get the challenge is that catastrophic expenditure because of healthcare, because healthcare costs, and it costs a lot, and somebody must pay. The catastrophic expenditure hits those people when they do not have, finances, they do not have a way that they have transferred their risk. So for this government and for UHC to work, one of the key pillars is that everybody must be on board. And for everybody to be on board, it required that we amend the Act to obligate everyone above age of 18. And to ensure still that everybody is on board, the government was also obligated to identify and pay for the indigents who cannot afford basic necessities of life, including healthcare. And then finally, the biggest challenge and the reform is to ensure that the benefit package that we offer actually addresses the needs of our people. So in the amendment, and right now we're actually launching our new benefit package with the contracts from 1st of July, which includes what has been termed as the UHC benefit package. But this has been addressing the growing needs of the people of this country.
Lastly,
and His Excellency, the President, actually kicked this off when we started having the packages from the year 2015 with the introduction of, the oncology package, the surgical packages, dialysis packages, etc.
Lastly, Dr. Kamunyu, what is the global practice in terms of insurance, and how are you borrowing that into the Kenyan system, especially with the roadmap to attaining UHC? Mm-hmm. Kindly shed light on that.
Thank you very much. Insurance is a risk transfer method. Like I said earlier, healthcare costs and somebody must pay. What we're trying to cure ourselves from is out-of-pocket expenditure. Because you cannot predict, you do not know how much, and very few of us can sustain that out-of-pocket expenditure, which drives 1 million Kenyans to poverty every single year. Now, transfer of risk. There are two ways you can transfer risk. Number one is you transfer risk to the government, whereby they use an input financing model, and they provide the commodities, the human resource, everything. But how is that financed? Is through tax. Again, increase of tax. The other way to do risk transfer is output-based model, which is insurance model, whereby you pool contributions or premiums, and you have a pot from which you pay for those who get sick. You have a pot from which you pay for what benefit package that you have prepared. Now, in terms of global best practice, that as a model of upscaling to UHC is a global best practice, whereby we use an output-based financing model. But after that, there are other challenges that come in. And those challenges that come in is in terms of costing of healthcare and ensuring that there's inclusivity in terms of benefits and the place of access. So that's why you find that the other best practice is that we move to what we call prospective reimbursement methods, whereby you transfer also the risk of management to the provider through different payment mechanisms, which include like capitation, which include like package fees, which includes things like diagnosis-related groupings for reimbursement. So that if you have, let's say, diagnosis-related groups like pneumonia, malaria, etc., you say that the components of treating that about the same, the time of the doctor, the nurse is about the same. So for any of these diagnosis-related groups, we reimburse 100 shillings. And that is the method that we're going. And why going that way? Because cost of healthcare is spiraling out of control. Where you have a fee-for-service method, it is fatally flawed to always lead to increased utilization and malincentives, which lead to increased costs.
Thank you, Dr. Kamunyo.
So as NHIF, as we are transforming towards strategic purchasing, one of the key things that we're doing is to ensure that our reimbursement method also is able to ensure sustainability of the fund. Thank you very much.
Let's clap for Dr. Kamunyo. Thank you so much. Now, colleagues, we are still on sustainable financing for transplant and transfusion. And as I said, PPP is very key, public-private partnership. We cannot do without the private. So at the end of the day, we also need to hear from the private. And at this juncture, I would like to welcome our panelist, Dr. Anastasia Nyalita, to give us the private perspective, both in terms of sustainable financing, narrowing down to transfusion and transplant, and also in terms of insurance, the private. Our hands together for Dr. Nyalita. Thank you.
Thank you, Dr. Lenai. And yes, Dr. Kamunyo served in the board of Kenya Healthcare Federation when I was on the private sector side. So he's also home to the private sector. Glad to have you, but I was just asking him, even if everybody paid, do you have enough financing? Would it be enough? If each of us contributed as we are mandated to, would that be enough? And I think this is a question that Lenai is asking, sustainable financing. Now, there's an analogy that Professor Kamarogo said in the morning about the lake and access to safe drinking water. And I would also say we have the same analogy when it comes to resource. I don't think, and I don't believe we have insufficient resources or shortage of money in this country. I think we went through the recession, and when the West was crying, we didn't quite, have, the pain was not as much. Also, I think. What we have is a fragmented situation. We've heard about the verticalization of programs. We have these very strongly funded disease areas. And then what about the rest? Who is actually providing the service in those verticalized processes? So essentially, we're actually just pulling apart the resources. So it's a high time, as part of a recommendation, that, and it was mentioned in the morning, we have to integrate these vertical processes. If a donor, and we really thank them for supporting us, we actually also need to ensure that whatever programs we have in the country, they're integrated, so that when a nurse is looking at a patient that has a certain disease area, if there's program disease like HIV, TB, malaria, and so on and so forth, they're also looking at the other patients as well, because they're trained, they're not just trained for that specific therapeutic area, they're trained across the board. We don't have luxury of resources, but we can optimize the resources that we have. So the one thing that we have as an opportunity area is really that verticalization of programs. Let's do something about it. That's very important. And then the fragmentation. I know fragmentation is not a big issue in the public sector, apart from, of course, now that you have 47 counties, and I'm a strong believer in devolution. The CEC, Molo is my immediate former CEC for health from Makueni, and you can see what it has done to the county and to the people at home, including my own, people who are, my aged parents who are actually benefiting from NHIF, and also the uplifting of the health at the county level, because then the question is being asked to the county government. So, but when it comes to the private sector, we need to kill that fragmentation, or we need to have some level of coordination, and this is what will also build us to be able, as we also do, collaborate with the government and the county and the national government.
So you're saying one sector approach?
One health approach. One health approach. Yeah, that's the one
Proceed.
health approach. Yes. So that fragmentation and private sector, especially, we need to work on that. And then there's a lot of wastage. We know there's a lot of wastage, not only of the commodities, but also of the resources, arising from the fragmentation, verticalization, and so on and so forth. So one of the things that, and the reason I'm saying there's no shortage of resources, we know we're exporting nurses human resources for health, for very good reasons, because we cannot absorb them. But if you look at, and one of the things I also like to look at is we have many philanthropists in this country, but I don't think health has been, until COVID hit. Health has never been at the forefront of their thinking, that we can actually invest in health. Now, if you look at, private sector came together through KEPSA, put in a lot of money under the COVID-19 fund, and it was a lot of money. And it really went to support, the government effort in the different areas in COVID-19 response. Why don't we have such a coordinated approach and make health a priority for everybody in this country? If we just focus on the health sector, it will never be enough. I come from Kenya Healthcare Federation as the health sector board of KEPSA. Now, KEPSA is the umbrella organization for private sector in Kenya. And if they can mobilize resources for COVID fund, then we can all pull together as a country and put up a resource for purposes, whether it's a blood, but also we have to sensitize people about the need for these blood drives. Until people are sick, that's the only time they wake up. But there's a business case for coordination of health beyond the health sector, because the workforce in the the non-health facility organizations, which are a bigger size of the economy, they have to be healthy for them to deliver. They now, everybody's aware, when COVID happened, they really needed their people to be healthy. So we have to take advantage of that. So what we are saying is that, fragmentation, wastage, we have to strengthen the health systems, but how do we make sure that NHIF and the other resources, we pull together, because we have to pull together sustainably. First, of course, I'm not sure if that has been done, but there are two phases. There's capital investment in whatever projects we're doing. Now we're talking blood. How much is required for sufficient capital investment? Forget about, being limited, number one. Number two, I know sometimes when you do health financing, when it comes to public sector, Kamunyo, you will cost without the human resources and the infrastructure that the government has already given you. You probably would cost only the commodities, yeah? I'm just speculating. But what I'm saying is that just like the private sector, that you cost everything, let's also cost across the board. What is the capital requirement, number one, for a really state-of-the-art, requirement for the blood ecosystem? And what is the recurrent? And then from that, so, what money do we have and what gaps do we have? And how can we raise that money? How we can raise that money? We can unlock private capital. We can have a case for the philanthropists, and there are many. But more important, I know there's this thing they call the sin tax, which is alcohol and tobacco. But there's also a lot of money there that is supposed to be repatriated back, or money that is, the asset recovery, for example. Those are opportunities we can bring into the health sector to especially fund the capital investment.
One last question before we go to
you
the
answer
plenary.
last question, but now from a sustainable perspective, because now you've taken care of the capital expenditure, then you're looking at the recurrent expenditure. Now, of course, this is where the sin tax comes in and other innovative ways of financing. And some of which, I mean, when we talk about VAT, for example, from private sector, really, we are overtaxed. But we're saying whatever tax you're already collecting, allocate a percentage of that into health, and specifically out of that, how much goes to the blood ecosystem.
Still on sustainability,
yeah.
I think in the private, the issue of sustainability will not have been addressed well if we are not able to balance or answer between profit vis-a-vis service delivery.
Yes.
So how is that being handled at the private?
I think when when you make profit, you pay 30% of that tax to government, which is what pays the bills. So it's responsible business, so to speak. So we should push more for responsible business, but still ensure that we're paying the 30% to keep the government sustainably resourced in terms of all the other sectors. So it is important to have economically viable organizations. And this is where as private sector we're really strong contributors in terms of the 30% corporate tax that we pay. And that's really organized. If you look at the Western world, the multinationals, they're the ones who really fund the government with the corporate tax. So that's something we must encourage, because also with that profitability also, you're able to build the economy, you're able to take your kids to school, you're able to pay for medication, you're able to pay for your NHIF and so on and so forth. So it's really responsible, sustainable private sector business.
The minister talked about not charging for blood transfusion. How are you as the CEO going to handle that?
Yeah, I mean, this is not the only situation where we are faced with being given products for free. The Kenya expanded program for immunization has worked extremely well. So the same model we will be able to apply in the case of blood. But in the event that someone we have our members or private sector charging for what have been given free, because typically we don't charge. If we charge anything, it's probably just the administrative costs. Then that we would be interested to know, so that we can see how to mediate and ensure that members of the private sector do not, businesses in private sector do not abuse the privilege that have been given by the government. Thank you.
Now, in some countries where we talk of UHC, some countries have achieved UHC because of blending between the private and the public facilities. How are we handling that in terms of the call for UHC?
I think for me, what I would say is partnerships, and probably that's where I should have started. Everything, when you incorporate partnerships, then you're building sustainability and also access and affordability. And I must say that at least what Kisumu has done with leasing out public facility to the private sector to run, it's something that needs to be. We from a private sector really are very excited about that. So it's about partnerships and sustainability, because at the end of the day, it's one health, and there is no private or public patient. We are all one. It's just one patient. So at the end of the day, how we responsibly manage that ecosystem is what is important. But partnerships across the board, not only in service delivery, even in human resources for health. One has access, the other one doesn't have access. How can we share that? Professor Muga has talked about bringing blood from one center to the next using the drones, and that's very important. And then, so it's a matter of you take that, and it doesn't matter whether it's a public or a private hospital that requires, a facility that requires it, they receive the same level of access. Because at the end of the day, you need to save a life at that point in time.
Thank you, Dr. Nyalita. I'm sure at the plenary, you'll have an opportunity to add more and more. Thank you so much. Dear colleagues, I know we have written into the next session, But let me take this opportunity really to call upon you to join me in applauding all our panelists. Let's put our hands together. Thank you, Dr. Kamunyo. Thank you, Dr. Nyalita. And without much ado, I would like to open up the plenary. Let's have the microphones going so that we handle this plenary very fast. Of course, questions are towards the ministry's bigger agenda of UHC and sustainable financing. The questions also are towards also the intergovernmental framework. The questions are also towards the private and also the best buy. That's NHIF. Yes, I can see one hand over there. That one was the first one. Introduce yourself. Not much about your CV. Then you ask your question. Tell us it's directed to who.
Right. Ladies and gentlemen, good evening. My name is Dr. Adel Ottoman, County Director for Health, Preventive and Promotive Health Services from Homa Bay County. I'm a public health virologist and health systems consultant for that matter. I must say that I am very elated and very happy and impressed on this conference, the Damu Ke Conference. Two is that I have listened to the presentations from panelists. Allow me to indicate that the presentation from the Honorable Professor Richard Muga, to me, is a blueprint. It is indicating a quite comprehensive way of dealing with shortage of blood and blood products in this country. And from where I am seated and listening to his presentation very well, we are only challenged as a country to see to the implementation or rather adoption for that purpose.
Your question?
Yes.
Your question, Dr.
Thank you very much. That was a comment from his side, his presentation.
Thank you.
My question really is to my friend Dr. Kamunyo, and I have listened to him, and I'm challenged to ask that for sustainable blood and blood products supply in this country, and for the purpose of UHC, is it possible in this country, Dr. Kamunyo, to go bold and enact another NHIF Act that would make this country to go and ensure that we have a purely additional tax that will take care of health in this country, to put everyone at same level than what we are seeing today, where some people are traveling up to India, US, and etc., and others can only go to a health center. Is it possible? And is it also possible that NHIF takes the responsibility of taking care of health workers? Because one of the issues is that health workers occasionally are not properly remunerated or paid, and the purpose of quality to make it equal, that what we get at a dispensary in Nairobi is the same service that we will get at a dispensary in Mfangano.
Thank you.
Thank you.
Thank you. I think, Dr. Kamunyo, you have two questions there, or two concerns you would like you address. Here. Let's be very fast because we are really eating into the breakout sessions. Kindly make sure the microphones are working.
Thank you very much. My name is Dr. James Beth. I'm a cornea surgeon in Moi Teaching and Referral Hospital. the only public facility so far that conducts corneal transplants. My question is very quick. I think this day has been a very good day because I think what blood transfusion services are doing, we can quickly do in cornea. US say that they save 6 billion just by getting people to see by corneal transplants.
What's the question, Doctor?
The question is, no, just confusing a bit. KNHIF currently reimburses 250,000 for each cornea. Would you consider supporting the biggest cost of that 250 is a cornea tissue. Cornea tissue is harvested from departed generous people. The mortality rate in Kenya is very high.
What is the question?
The question is, would you consider supporting corneal eye bank services so that it reduces the cost of corneal transplants and increase the access in public hospitals? Thank you very much.
Dr. Kamunyo, over to you. Next, I think 2 from this side. Let's have 2 from this side. A lady and a gentleman. Kindly ask the question. I only have 3 minutes.
Yeah, thank you.
For
My name
answering the question.
Sure. My name is Rema Gisaka from the University of Nairobi. My question goes to Professor Richard Muga. So I guess for the few years I've had a case of our government people going to Rwanda for whatever benchmarking and the like. So my question is about the barriers which limit the adoption, rather development of those technologies. We're talking about zipline and the like. Which barriers do limit us as a country to develop those technologies, considering the cost of uptaking technology, rather than us trying to develop our own?
Barriers to adoption and developing our own innovations and technology. Next, I see the lady.
Thank you. I'm Elizabeth Mugwa. I'd like to address my question to NHIF and the PPP representative. Yeah, so in line with UHC pillars and especially affordability, what are they both doing in terms of reimbursing post-transplant medication? Thank you.
Thank you. That's straightforward. This side, yeah, gentleman seated over there. Not you in the front over there. See you, not you.
Thank you. Mine is just a comment about...
Your name?
My name is Dr. Geoffrey Omuse. I'm a clinical pathologist working in a private hospital in Nairobi. Just on the comment around that blood needs to be given free. I'm glad that the speech read on behalf of CAS clarified that we should charge reasonably. Oftentimes, especially we in the private sector, are at the receiving end of the wrath of patients and consumers of our services, because tomorrow the headlines will say that hospitals should not charge a shilling for blood, yet there are other related costs beyond just being given a free pint, and there needs to be a reasonable charge. So I think we should be talking about reasonable charging, not necessarily free, because it's not really
How much is reasonable?
We can have a discussion on
then,
this.
yeah, so I think the issue is we all need to agree how much reasonable is reasonable. So don't charge before we agree. As the CS said. Next, lastly on this side, I think let's take those questions, then we go into the breakout sessions. These panelists will still be available, just a phone call away, so that we can continue engaging. Let's start with Dr. Kamunyo. You seem to have a lot. You can stand here. You can stand
here. Thank you, first of all, the first question, Dr. Ottoman, for your query. And you asked about can we have additional tax to put everyone at the same level? You know, NHIF and where we are as a country, it's a very unique scheme because 100% funding of NHIF is from your contribution and my contribution. In fact, when you look at other countries that are also stating that they've achieved UHC or they are at an advanced stage of achieving UHC, you'd find that the financing includes a lot of tax funding. And another unique thing, maybe I'd like to mention to Dr. Lenai, is that also for us, in terms of achieving UHC, the interplay between public and private is also more advanced. Most of the other countries that have achieved UHC, the area of access is mostly to public facilities, not to the private facilities. So we have a very unique blend of having the contributors as the sole funders of the scheme, and also that we have a huge interplay between public and private. In fact, it is an oxymoron because 75% of our providers on the panel are public facilities, yet more than 70% of what we reimburse goes to private. But the reason why that happens is patients choose to go there because of consistency and availability of service. So that is the challenge that initially I was actually also posing to ourselves in the public sector. So ensuring that we have additional tax, that would be very welcome. And especially for what? Especially for those services like preventive care, for services that would involve other public good issues like, you know, the corneal bank we're talking about and all that, supporting that. That I would actually propose that we actually get there. Because right now, even sustainability of the fund, Dr. Lenai, is being challenged by the voluntary contributors because they only contribute when they have a need. So you find that at the moment, for every shilling we collect, we're actually paying out 3 shillings. So this is something that we need to actually look at to be able to cushion the fund and to expand the benefits to more preventive and public good benefits, as opposed to the defined benefit structure that we have right now. Taking care of health workers, number one, NHIF is there for everyone. All Kenyans are already covered under the super cover, which we've expanded the benefits in the new contracts we're going to have. But for civil servants, you recall when COVID hit, His Excellency the President actually gave a directive that we find a scheme that will be able to handle the frontline workers and who have dedicated themselves. And that included now all public servants that we have a scheme for, and also the National Police and Kenya Prison Service. And also many counties have also taken up. So in terms of taking care of the health workers, it would be the onus of the employer to increase beyond that which we have provided as the national scheme cover. And that would attract, of course, an extra payment. But the mechanism for that is already in place. And like we said, healthcare costs and somebody must pay. So who is that going to pay? Then there was the issue of same service at all facilities. How can we ensure that the services at the level 3 in Matungulu and the level 3 in Kariobangi is the same? One of the things that will drive towards curing that is our new contracts. And our new contracts that we are launching from 1st of July have standardized the reimbursement across all levels. So we've addressed all the issues. So we are not reimbursing based on a facility. We are reimbursing based on the service being provided. Because from wherever it is, whether government facility, the human resource has been sponsored, or in a certain faith-based facilities, there's some church group paying for certain services. But at the end of the day, those services have been costed and will be paid for. And that is why even right now we have a team going through to get what is the actual costing of healthcare. Because we've really not dug deep to that. And that would explain what that normal charge should be for offering a service for goods or commodities that have been provided for free. So that is what we need to look at. And beyond that, when you have systems and processes, you'll not be able to overcharge. And if anybody overcharges, that is medical fraud. And we have other mechanisms of taking care of that. So I think the question by Dr. Bett regarding the corneal bank, etc., we need to look at and understand, like NHIF is an insurer. We pool, and then we will pay for an occurrence that might happen, or maybe not. And that's why the way we've calculated, or the premiums are calculated, is based on the risk of a certain community. So paying for preventive, paying for service tends to be something more to the government, whether it's a county government, a national government, and these are things of public good. That's why you can see the efforts that have been made to make sure now Damu Ke is there and blood is available, etc. So those are things that we need to look at, but how do you sustain that is because we do reimburse for those treatments. So we already have a mechanism that upon utilization, you're reimbursed and you're able to continue giving that service. Finally, the question on post-transplant medication, we are actually addressing that. Like I told you, we actually do cover transplants. For post-transplant medication, one of the challenges is because now the medication you get it as outpatient. Outpatient has certain limits because we do capitation for outpatient, but we are actively looking at it because we want to look at case costing so that a whole case, so once we do the transplant and post-transplant, what is what we will be able to do that. And that we know that in the long run will actually be cheaper and has a better quality of life for the patients. Thank you very much.
Thank you. Thank you. Let's clap for him. Next, I think there were a couple of questions to PPP, private mainly. Maybe one.
On PPP, I'm not sure.
Or it was being combined.
It was being combined.
Okay.
But I wanted to just speak to the corneal transplant question, because I happen to have worked in Myanmar where, they have this program where, when you're still alive, you actually sign up to donate and to the corneal bank. So I believe that is something for Dr. Nduku, where is she? Which we can actually start looking. Maybe it's already in the policy or the framework. I've not looked at the guideline yet.
As a resource mobilization strategy. The resource is the cornea.
So just like you have the blood bank, you also have the corneal bank. Yeah. So you don't have to pay that 250. It is consolidated. When it is needed by a patient, they only pay the nominal fee, which we will, to be costed and agreed. Because, 250,000 is something that, and like I think one of the speakers said, when we go down, we go with a lot of resources that can actually be tapped before then. It's really cultural, and we have to find a way of changing, accepting and changing that culture, because I think that's one of the things that...
Lastly, can we hear from Professor?
Thank you very much for a very good afternoon, very good sharing. A very good question came there. Why can't Kenya develop? What are the barriers? Why must we go to Rwanda? But let me tell you, the technology in Rwanda is not that they discovered it. They have already brought it and they are operationalizing it. Drone technology is very old. It has been in many, many countries. And also to tell you, NHIF, many countries have come to learn what NHIF is doing. They copied. They went back and they did it better than us, okay? So it is possible that one country, particularly African countries, you can go and learn something and come and implement. And like we are being told about the cornea, I think this is something that CEO NHIF should be able to seriously think about. And those of you who remember Ngilu Bill had some tax-based support. But when it went to higher level cabinet, it was killed. And now we have the new ones. So sometimes in Kenya, you kill, then people come past you, then now you run after them, and you go and learn from where they have reached. This is a unique behavior of Kenya at some times. And let me also indicate that going forward, when we share some of these proposals, we are not telling you people to come and adopt now. It is for debate. Debate it. Look at the pros and cons so that you can see what is it that we can take forward. So I had my student Ottoman saying, can we adopt? No, no, no. You don't have to do it that way. But we must allow new ideas to come on the floor, then we debate it. And I would like to ask CECs who are here that this is our time. We should also weigh some of this, and then we can recommend it to our governors. I think this was a good afternoon. Thank you very much.
Thank you, thank you. Let's clap for the panelists and our presenter again. Thank you so much. We still want to apologize that we have really eaten into the time of breakaway sessions. I'm being reminded that most of the things that we would want clarified will be handled during the time of breakaway sessions. So Dr. Kamunyo is still available and will be circulating and will be with us. And Dr. Nyalita will also be with us. And our able Professor Chair will also be with us. So during the breakaway sessions, we can continue engaging. And I want to thank all of you for the participation and very lively engagement. And I know a good beginning of matters, transfusion and transplant has started. Thank you and God bless all of you. Karibu sana. Meanwhile, I have some announcement. The officials for the county directors for health, kindly you see Chepkok. And also, the officials of the chief officers for health, kindly see Chepkok. Thank you. Over to you. And apologies.
Can we please appreciate the panel a little bit more? I think we've learned a lot from this team. Thank you so much. Just to let you know that on your way out, pass through the room where you met as panelists. Yeah, we want a word with you guys just before you go. As you go out, the room where we met as panelists, I think it was room 412, right? Pass there. All right, thank you so much. And hey, can we give them one more round as they walk out? Thank you for those brilliant ideas. I really like the private sector angle in the whole story, yes. So, I saw some of you are still raising your hands because you are not satisfied. But I want to tell you we have a menu of options for this afternoon that will definitely make you more satisfied. We have 4 breakout sessions going to happen starting now. Now, I want you to listen to me carefully. I know we have to pass by the tea place, but I'm recommending, because of the time, you just pick your tea and walk with it. It's a long walk to freedom. We're going back to the hotel. In the reception area, you will see directions to whichever track you're going to go to. We have 4 tracks. Let me just go through them quickly. The first track is track A, which is looking at what is required to strengthen pharmacovigilance and organovigilance systems in Kenya. All right? The room for that track, you will see the sign just as you get into the reception area. Breakout session 2, track B, innovation in transplant, infectious disease, and transfusion transmissible infections. Wait, this one I cannot read. Yeah, innovation in transplant, infectious disease, and transfusion transmissible infections. All right? That's the second track. Track C, innovative approaches in refilling the blood banks, lessons learned from counties. Strengthening blood supply and distribution systems, that is track 4. Now here's the deal. What is the time right now? It's 5. At 5:15 on the dot, we're going to start the sessions. So try and get your tea very quickly. The tea is a takeaway cup, and get into the room of your choice. I want to tell you that the presentations that have been prepared for these breakouts are really, really scintillating. So don't miss, don't rush home. You need to hear what our panelists have prepared. I also want to say one last thing. For those of you who want to earn your CPD points, there's somebody who's going to be in those rooms, those 4 rooms, showing you how exactly you can earn your CPD points. So that is the carrots. Enjoy your session. God bless. And tomorrow morning, we are starting at 8:30. Please note, we have a very full session tomorrow. So the first plenary is going to be at 8:30. So please be on time. God bless you and see you tomorrow.
Upendo wako mfalme, tungekuwa wapi? Kama sio neema yako mfalme, kama si nguvu zako, tungekuwa wapi mfalme?